All right, I'm Dr. Peter Apel. I'm a hand and orthopedic surgeon here at Virginia Tech Carilion, and I'm going to be speaking today on targeted muscle reinnervation. What's the deal? So before we can really understand targeted muscle reinnervation, we have to understand nerve transfers. So the history of nerve transfers goes back all the way to 1903 with the first nerve transfer that was performed for a facial nerve palsy. And so this was actually an into-side nerve transfer. Here's the patient. He has the strabismus on one side that's unrelated, so don't look at his eye. But he's got the facial paralysis there on the left, and the nerve transfer is performed. And you can see now he has some improvement in the facial paralysis, where the spinal accessory nerve was grafted to the facial nerve. So, and nerve transfers then evolved over the next century. And here's a brief timeline where we had the spinal accessory nerve to facial nerve, and eventually, with Tuttle in 1913, did nerve transfers for brachial plexus injuries. And this progressed all throughout the 20th century with Vulpius, Harris, Forrester, on to Seddon. And then in the 1990s, Novak and McKinnon, and then Oberlin with what is probably the most famous nerve transfer, or most successful nerve transfer, the FCU fascicle to the biceps. So the real thing we want to talk about though today is TMR. And where did TMR come from? And the answer is it really came from nerve transfers. What I'm going to call super close nerve transfers, which were done for myoelectric prosthesis creation. So the muscle was needed to give a signal to the myoelectric prosthesis, and motor nerves are then brought down into the muscle. And it's called targeted muscle reinnervation, hence the TMR acronym. But it essentially was discovered as being effective for neuropathic pain in about 2014 by the group at Northwestern, who was performing these super close nerve transfers for myoelectric prosthesis planning. And in a way, TMR was discovered much like the drug from Pfizer, Viagra, where it was originally created for one thing, but as it turned out, its best effect was for another thing. So looking at targeted muscle reinnervation, here is a history of PubMed results for targeted muscle reinnervation over the last 2 decades. So first study with that term was published in 2004, with very little progress in these first 10 years, as it really was a technique for a very narrow prosthetic indication, that is the use of myoelectrics. And it wasn't until 2014 that we saw it be beneficial for post-amputation neuroma pain. And here is the study that showed that came out in 2014 in CORE, which really then changed the face of management of neuropathic pain, specifically, post-amputation pain, and has created huge interest in using TMR for management of that post-amputation pain. And there have been some pretty incredible results. I mean, that's really the only way to describe them. There have been randomized controlled trials. Here is the masthead from the randomized controlled trial that was used to treat targeted muscle, used to treat neuroma and phantom pain in major limb amputees. This randomized controlled trial. The literature also has multiple level 3 studies, and specifically for below-knee amputations, there's a 90% improvement in revision cases, improved phantom leg pain, and less than 30% of patients will have symptomatic neuromas when this is performed primarily in amputees. So, but myoelectric prosthesis, right, is not a reality for most. Most patients just don't financially have access to myoelectric prostheses. And so we end up doing, in practice, TMR for the management of painful neuromas or the prophylactic treatment of painful neuromas, because that's far more common than patients who are going to have access to myoelectric prostheses. And here's a picture that I got from Sue Jordan with her permission to use, essentially shows the basics of TMR, where the major nerve that's injured has this end bulb neuroma, it's cut off, and then that nerve is transferred into the motor nerve to the muscle. And what we believe occurs is that the nerve grows into the muscle, and the motor nerves to the muscle, they're not really motor nerves. They're actually only about a third motor nerves. They're about 2/3 sensory fibers. And that's been shown in several basic science studies that have looked at the composition of the motor nerve going to the muscle. And because of that, what happens is the nerve that's implanted into the muscle at the site of the motor nerve to the muscle grows down and reinnervates. This has yet to be shown, but probably the sensory receptors inside of the muscles, and then create functioning sensory neurological units between the sensory end organs, whether they be stretch receptors, chemoreceptors, baroreceptors, and the brain. And by having intact pathways, it's thought to decrease the amount of neuropathic pain. So here's a case example. This is from my own practice of a patient with recalcitrant deep perineal nerve neuritis. This was a 42-year-old male. He'd already had a previous neurolysis and hardware removal. He had persistent pain in this region. He had failed topical treatments and had a favorable response to a diagnostic injection, and just had this, horrible mononeuropathy, neuropathic pain in the deep perineal nerve. And so here's what we did. So this is a dissection between the EHL and EDL. We dissect down onto the anteriotibial neurovascular bundle, including the deep perineal nerve. And we pick out here, this is a motor nerve, to the EHL. We have the blue vessel loop around. And the nerve has been transected well proximal to that zone of injury. So that big keloid scar you saw on the anterior aspect of the ankle, we're way above that. And so we cut into normal nerve way above that. And it's then brought and coapted to that motor nerve to the EHL. And you see how close that is, why TMR is really a super close nerve transfer, because the nerve is brought right to that junction where the nerve starts to go into the muscle, and then it's coapted there and held with either 11-0 nylon or fibrin sealant. So in this case, we had a remarkable result. The patient was seen here. Here he is at about 3 months out, and you see he does have a little tiny droop to his toe, and that comes from some of that EHL weakness. But overall, he's extremely satisfied. He is able to shower without pain when the water hits his foot. He's able to put his sock and shoe on without pain. That was new for him. It was very painful from before, and at this time he was asking to go back to work. And so you see here, how far away the surgical incision is from where his previous trauma was. And so this follows our basic nerve principles, which is that nerves need to be resected back out of the zone of injury. Whether we're doing a nerve reconstruction, or in this case, a TMR for neuropathic pain, we've got to dissect out of the zone of injury, because the damaged nerve at the site of injury does not have the capacity for normal, healthy regeneration. Instead, we have to get way out of the zone of injury. So you might just say, well, why don't you just, resect and graft? And so here's some reasons why we may choose TMR over nerve reconstruction. Because we know that nerve reconstruction is imperfect, that reconstructed nerves, they're always tender. And some are really not amenable to nerve grafting because of their superficial location. So the SRN at the wrist, superficial perineal nerve in the foot, deep perineal nerve, in this case in the ankle, right as it comes, subcutaneously. Sural nerve is a subcutaneous nerve, MABC, LABC. These are always going to be superficial, even if they're reconstructed. And so that site of neuropathy and that nerve graft is going to be superficial as well. In addition, in this case, as in many other cases, there's a long zone of injury. And sometimes it goes all the way to the most distal end of the nerve, where they become, where the distal targets are very, very small. So there needs to be an alternative to nerve resection and grafting, and in these cases, TMR may be beneficial. So there's plenty of upper extremity TMR opportunities. I have found the superficial radial nerve to do quite well with TMR. In my practice, it can be resected back all the way to the level of the elbow and then brought into the ECRB, the motor branch to the ECRB, or the motor branch to the supinator. It's a great size match. The SRN is to the ECRB. And it can be quite powerful for recalcitrant superficial radial nerve pathology. The LABC is pretty easy to get to the same recipients, to the ECRB and the supinator. It really does quite well, and I've had a lot of success as well at the dorsal ulnar cutaneous nerve to the AIM, where it's brought back to the level of the mid forearm, back in here to the mid forearm, and then brought deep down to the AIN, which is just the motor nerve to the PQ at its most terminal aspect. So, you might ask, well, where's the evidence for this? Well, the bottom line is there's little to no evidence at this time, February of 2022, for TMR for neuropathic pain in non-amputees. So a lot of these practices are coming from the theoretical benefits that we know and the inferred conclusion that is derived from the BKA literature and elsewhere. Certainly this is emerging. It seems like every month there's another study on TMR or another investigator who's got data on this, and all of it at this point appears to be promising for management of this neuropathic pain. Maybe it's foolish, maybe it's visionary, maybe it's too early to tell, one or the other. Time will tell whether or not TMR for neuropathic pain is a revolution in the surgical management of nerve-related pain, or whether it's a passing fad. I tend to think that this is a technique that's going to be with us to stay and is going to be a real game changer in the management of neuropathic pain going forward. Alternatives to TMR include nerve grafting or nerve transfers. This is an example of the MABC transferred end to side to the ulnar nerve. This provides a appropriate channel or pathway for the sensory nerves to reinnervate. We know that they can reinnervate end to side into a larger nerve like this. And then RPNI, which is essentially taking a thin sheet of muscle and wrapping it over the nerve end. This is a free muscle graft, essentially, 3 to 4 millimeters thick, and wrapping it over the nerve wrap like a tortilla or like a crepe. And that provides the sensory organelles for the nerve to directly reinnervate into. I did just come back from the ASPN meeting in Miami this year, several presentations on RPNI. And at this point, it's looking like RPNI is probably going to be comparable to TMR in the quality of result for management of neuropathic pain. That is yet to be definitively established, but it sure looks like it's going to head in that direction. So in the future, what does the future hold for management of neuropathic pain? Certainly, there needs to be a definition of standard TMR transfers. At this point, there's not really any standard for where SRN should go, where DPN has to go, and even in amputees, it's not always clear. There are certainly authors that recommend certain patterns. But in the end, it's kind of an any port in the storm approach, that you try to get that nerve to whatever muscle you can get it to, where you can find a recipient. I think we also need to see a bit more robust investigation of TMR versus RPNI. Certainly TMR is technically more challenging. RPNI is less so. We also are going to need prospective database studies on the surgical management of neuropathic pain, likely multi-center, to tell us if this is really making a big difference in these patients, non-amputee patients, like we see in the amputees. So these are a couple of my mentors, Dr. John Lee at Wake Forest, Dr. Andy Komen at Wake Forest. Dr. Komen's there in the center, Dr. Lee's to the left. Just want to give them a big thank you for all of the education they've imparted to me over the years on nerve and nerve-related problems. Thank you for watching. If you have any questions, go ahead and put them in the comments. Once again, thanks for your attention.